everyone for joining us today for our presentation. Just a reminder to go ahead and type any questions that you may have in the chat box down below. We are recording this webinar, and we'll have the recording up on our website later today. And with that, I'd like to hand the presentation over to our presenter today, Dana Zive.
Thank you so much, Hannah. I appreciate it, and welcome everybody. Looks like we got reasonably nice turnout, and I know a number of those names, so hi. Thanks for joining us today. So I'm Dana Zive, and I am the director of the Oregon POLST Registry. I'm non-clinical research faculty in emergency medicine, which is where our statewide registry is housed. We operate under contract with the Oregon Health Authority, and I have been fortunate enough to work with the registry since its inception. And what we're going to do today is kind of just give a little bit of background about the registry and then talk about some of the technology initiatives that we've undertaken. So, and as Hannah said, this is recorded. I believe the slides will be available as well. If there's any questions, I believe, and Hannah, correct me if I'm wrong, but you just type it into the participant feedback box, and Hannah will make sure that I get those when we get to question time.
Yep, sounds great.
So, okay, awesome. So what I wanted to start with, so we do have someone from one of the groups that we've worked with in the technology that we'll be talking about today from the Emergency Department Information Exchange. Adam, would you like to go ahead and introduce yourself?
Certainly. My name is Adam Green. I am one of the founders of Collective Medical Technologies. We make the Emergency Department Information Exchange, or EDIE as we lovingly call it. I think Dana will describe a little bit about EDIE in some of her later slides. My role right now is head of product and development, and that's who I am.
Thank you so much. We wanted to make sure there was someone to potentially answer more technical questions should they arise. So Adam, I'm going to mute your line again. So I wanted to start, as always, with conflicts of interest, just to make it clear. So this webinar is sponsored by the National POLST Paradigm, and we're very grateful for the opportunity to present. The registry itself is funded by the Oregon Health Authority and operated under contract with Oregon Health and Science University, or OHSU, which is where I work. The Oregon Health Authority also provided funds to support projects that we're describing here, and I do receive salary support from the Oregon POLST Registry. Finally, there's some discussion of third-party developers and vendors who were engaged to create some of the work that we'll be presenting, and I just want to make it clear that there's no indication of endorsement or advertisement for those groups. They're simply ones that we have worked with here in Oregon. So with that being said, let's start. So today I really, as I mentioned, want to just start with a little bit of background of the Oregon POLST Registry to review our original structure of POLST form access, to describe what we call bidirectional form transmission, and then to describe the statewide automated dissemination of POLST forms that we're moving into. So those are our basic goals for the day, and if you feel like I haven't hit on any of those, feel free to ask me any questions. So the Oregon POLST Registry, what is it? Well, it's a secure electronic record of POLST orders. It is a database. It is a straightforward repository of forms. So it is not a system that people can create their POLST forms within. It is not a publicly accessible website. It is a secure database that is housed here at OHSU, through which we have worked on making a lot of technology connections. Originally, the goal of the registry was to allow emergency medical professionals access to POLST orders. And our focus was really EMS agencies in the field. There was a study done, I believe, in 1992 where EMS people were asked the last time you were on a scene where you would have expected to find a POLST form, how often was it not available? And it was over 25% of the time. And that was really the basis of the development of a POLST registry, because in a time of an emergency, POLST orders, which are physician orders for life-sustaining treatment, are really critical for EMS to be able to provide treatment that matches a patient's goals of care. You can actually see a sample POLST form from Oregon on the right-hand side. The critical elements in an emergency are obviously sections A and B, which speak to CPR, and then medical interventions, which include whether or not a patient would want to be intubated or to be transported to a hospital, which obviously would be critical for EMS. So if the original POLST form cannot be found or isn't present with the patient or can't quickly be identified, they can contact the POLST registry. The registry was built as a backup system to support the forms, and it does not replace original POLST forms. We actually did start very much as a backup, and it seems now that we get a number of requests, even if people are looking at a POLST form, to confirm that they either have the latest form to guide the treatment that they want to provide for the patient. So we were piloted in a single Oregon county in 2008 from funds that were philanthropically received, and we went very quickly from a 6-month pilot to having a legislative mandate for the development of a statewide registry, which includes actually mandated submission by the signer of a POLST form, which here in Oregon are physicians, nurse practitioners, or physician assistants, or their designee. So that means that an office member, an office staff in a clinic, for example, could be the one who sends information, or the health information management group of a hospital or health system. We went live statewide on December 3rd of 2009, and we had no idea what to expect in terms of volume, and it definitely started going fast pretty quickly. This slide demonstrates the cumulative POLST forms that we've received by year. Because we started in December of 2009, most of our reporting focuses on years starting in 2010. And you can see from this slide that our volume has increased every year, well, with slight variation in between 2011 and 2012. So, and we are on track this year for 2017 to break the 60,000 mark for the year. So overall, we have received over 350,000 POLST forms for over 240,000 Oregonians. Because we collect POLST forms anytime that they change, we actually do maintain a historical representation of POLST forms, because updates are a significant proportion of what we receive. That could mean that someone simply has new demographic information, they've moved, or they're in a different care setting. But it also could mean that their orders change over time. We know that POLST is a dynamic, voluntary document, and so we always want to make sure that we have a mechanism to support those updates. And so if you're wondering why it's 240,000 Oregonians and 350,000 forms, that's why. So our monthly volume in 2016 was between 4,000 and 5,000 forms per month. So far in 2017, that's been up to more between 4,500 and 5,500. So every year we seem to have increases in POLST form submission directly to the registry. And POLST forms are submitted in a number of ways. Pardon me. The primary way that we receive POLST forms is through secure electronic fax. This is a system that almost anyone can use, has been, especially in any clinical setting, been very sort of used to that as a standard. We also have secure file transfer connections with a number of institutions who submit forms electronically, and I'll talk a little bit more about that. We also receive copies of forms in the mail, sometimes from individuals and sometimes from smaller clinics or health systems. and we'll take them however we can get them. The one thing is if people send us their original forms, we make sure to send them back really, really quickly. So how do people, emergency healthcare professionals, access forms? Well, the way that the registry was built was as a closed system. So basically, it was a secure system using a 24/7 call center housed here at OHSU and staffed with emergency communications specialists. So these are people who take calls from EMS and other emergency departments every day. So they're the transfer center for traumas. They manage hospital capacity. They handle what we call online medical control, or the medical resource hospital for EMS. So it was a place that EMS was used to contacting, either by radio or by phone. We're very fortunate to have this group exist at OHSU because it basically gave us a primary 24/7 group that could manage this and manage it quickly. Contractually, we're obligated to provide the POLST information in 2 minutes or less in 90% of cases, and I can tell you that the median of time is usually 53 seconds. So it tends to be pretty quick. Now, who can contact this group? So EMS, emergency department, and acute care units can call. This is not a public number. It's not a number that's shared with any other groups than folks who we would expect to be providing acute care and emergency care. And while the system was built for EMS, we've actually been interested, or it's been interesting to identify that emergency departments have in fact made up over 50% of our callers in the 8 years that we've been operating. So what started happening is technology started changing. If anyone can remember back in 2008, it was maybe your first or second smartphone, the first times that electronic medical records were completely accessible across multiple institutions, including skilled nursing facilities. I'm trying to think of some hits of 2008 and 2009 that people would remember, but I think I was just in a blur that year because we were so busy with the registry. But one of the big things that we identified coming down the pike was electronic form completion systems. So we first started identifying these systems in about 2011 and 2012. And what we found was that there were a number of vendors and other groups who were creating software or web-based modules that would allow the documentation of POLST orders, in essence, electronically completing a POLST form. So what's cool about that is it allows programming built in to reduce completion errors. So what are completion errors? They're things where a form is not considered valid if it has conflicting orders, for example, or a form that's missing a date of signature, or a missing patient name or signer name. I'm going to go back to a slide here. You may have wondered why there's two different colors. So the blue actually indicates forms. Oh, it's actually backwards on this one. Sorry about that on the label. But the blue indicates forms that are what we call not registry ready, that don't have some element of that validity. It also includes forms that maybe were printed on a non-standard pink color that unfortunately doesn't fax or copy well. So it could be that the form is illegible, or it could be that the form has one of these completion errors. And that is, as you can see, generally between 15 and almost 20% occasionally of forms that are received by the registry. So we ended up putting a lot more time into what we call not registry ready forms than we were ever expecting to. So when you can have programming to reduce those completion errors and to potentially pull information automatically into the POLST form, You have obviously an opportunity to reduce errors, and it can also include real-time education, including guides for conversation between a provider and a patient, or patient-level information. Also allows multiple languages potentially for language compatibility, and really supports the quick processing of POLST forms and often direct submission to a registry like ours. So as we started hearing more about those, we knew they were coming our way. And we found out that they may be standalone, they may be integrated into an electronic medical record. As I mentioned, if there's additional documentation, checklists, or anything else that needs to be present in your state, then it can include that documentation. The form is generally printed out for signature, but we've seen a significant change in that e-signatures for providers and patients can be captured or electronically displayed, but they also can be captured through a mouse signature or digital linkage to smart devices like tablets or smartphones. So I see a question over here that asks, does it have an electronic signature? It certainly has the capability. And when I say it, I want to be very broad. It's really they. There's a number of vendors who have developed systems like this, including internally developed systems by health providers themselves. Here at OHSU, we utilize an ePOLST system that does allow the capture of patient and healthcare professional signatures. So ePOLST are currently in place in Oregon in a number of health systems and some of the larger ones throughout the state, and they do allow direct registry submission, which is important because you want these forms, or we certainly want these forms, to be able to be entered and accessible as quickly as possible post-signature. And if they don't have errors, it makes it all the better. So, after the development of ePOLST and the building of systems that would allow ePOLST to talk and communicate directly with the registry, we started to identify even more changes that were going on. And in 2016, the Oregon POLST Registry partnered with the same vendor who created the OHSU ePOLST system to actually have an EMR-embedded bidirectional linkage. So what that means is that forms completed anywhere, not just at OHSU, can be accessed through the hospital's EMR with what we call one-click access from the patient header. So it's not just searching through forms that were developed or submitted at OHSU, not just looking at electronic forms, but looking for any form that exists, anything that's held in the registry. So it means that the system is actually fed by the registry twice a day so that viewers, and any healthcare professional can be a viewer. Others are limited to being able to be a signer, for example, because it's an ePOLST system. So even if those were completed at another institution, OHSU users can now have access to the over 165,000 active forms in the registry. So if you're wondering why there's 165,000 active forms as opposed to the 350,000 that we've received, one of the things that we do is every quarter we actually archive patients against the Oregon Death Registry. And that is to make sure that we have the appropriate pools so that when the search algorithm is utilized to identify a patient and a matched form, it's got the, the most likely accurate information. So, and now what are we doing? So once again, even though that was 2016, we're seeing things change even faster than we've ever known. And we're very fortunate that the Oregon Health Authority has supported us and actually guided us, by guided I mean told us, to make connections available through the registry. So we are right now finalizing work to allow access to POLST forms at every hospital in the state using the Emergency Department Information Exchange, or EDIE. And this means that over 60 hospitals in Oregon will have utilization access through this information exchange. So EDIE, I'll do a quick summary, and then if Adam wants to add anything, I'll make sure that he can. So EDIE was developed by Collective Medical Technologies in 2006. And essentially, it works to curate or document treatment information for patients across settings of care, basically emergency department patients who have presented to different emergency departments, for example. And that includes looking at information from the prescription drug monitoring program or looking at ED utilization. So if there's a patient who's had more than, for example, 5 ED visits in a set time frame, that could be a trigger for information from EDIE. And now we're adding in POLST data. So Adam, is there anything you want to add about what I just said? Okay.
Another thing that we add to that curated information when available is care team for the individual. So that could include primary care provider or care coordinators involved in the care of the individual, as well as the other point that this information is proactively pushed down into the emergency department to fit within the workflow of the emergency department. So emergency physicians obviously are very busy individuals and don't always have time to go check various other sources. So if it's not within their EMR or within their workflow, they're less likely to get access to that information. So one of our goals is to put it into their hands without them having to do any additional effort.
Awesome. Thank you so much. And I'm going to leave you unmuted so that you can step in if there's anything that you want to add. So how is EDIE going to work for POLST? So as Adam mentioned, this form will actually be delivered in under a minute through multiple routes or through basically a hospital-selected route. It could be either through direct EMR integration, secure fax, or direct hospital printing. Those are things that the hospital determines when they're doing their EDIE setup. So what will people receive? They'll actually get a PDF of the patient's POLST form that's held in the registry, and it will be sent directly without required individual querying. So essentially, on registration in the emergency department, I got to the wrong slide. So they'll get the POLST form, and they'll also get a set of information to guide healthcare professionals to do the critical elements that they would need to anyway when receiving a POLST. So they need to confirm the demographic information, and it also indicates critical information from the form, like the POLST form's date of signature when the order was made valid. And this is in case a patient, for example, presents to the ED with a newer POLST form. That could certainly have happened, one that the registry hasn't received yet. It also includes the patient's POLST registry ID. Every individual registrant who's has forms put into the registry receives a unique identifier. So regardless of how many forms they submit, there's a unique identifier for each patient. By allowing that, if there needs to be a follow-up call to the registry or any follow-up information, it's very easy to identify the patient with their POLST registry ID and just a couple of other pieces of information. So by giving healthcare professionals both that cover sheet and the actual POLST form, they have what they need to implement the orders should the patient's acuity warrant that. So, a lot of times patients are coming into an emergency department and they're not sick enough, essentially, to invoke the POLST orders. They're not looking at whether they need CPR or not. There's not an issue with them being intubated or sent to an ICU. However, it certainly may help guide treatment and family decision-making and patient decision-making in the emergency setting. And it means that whether or not you have bidirectional functionality or an ePOLST system, that you're going to be able to get access to that POLST form without necessarily having to call us. And plus, we'll be able to generate utilization metrics. A lot of what we do in the registry, we report in both monthly and annual data reports. And at the end of this, you'll be able to see the website where you can access that information if you're interested in it. So what I want to make sure is clear. So EDIE, not a POLST form completion system, but now is essentially a third mechanism to allow access to POLST forms, and one that is done in a hands-off way in under a minute, similar to calling the registry, but as Adam mentioned, part of the regular workflow. Because emergency departments are already used to receiving these EDIE reports on specific patients, it should not be a surprise or a challenge for them to understand what it is that they're receiving for patients when they get a POLST form. Pardon me. So the cool thing about an additional route of access is that as we, the registry, work with more electronic systems, more forms, correct forms, are available sooner and through more routes than ever before. When the registry was envisioned, we really didn't have any idea that we would grow through all of these systems. So now what? Well, the registry continues to work with electronic systems like direct secure messaging for POLST form submission, or the back and forth that happens around not registry ready forms. And we're also working with the long-term care continuum and other groups to identify effective electronic completion and access opportunities. I want to make it very clear that the registry is not just for hospitals. POLST forms are not just utilized in hospitals. And currently, to access information for skilled nursing facilities or other folks in the long-term care continuum, they utilize our business office, which is available 5 days a week during regular business hours, and takes between 550 and 750 calls a month, often for what we call non-urgent POLST form requests. And so while there is a mechanism, it certainly is much more like the standard call us and we'll help you. And so we're looking at opportunities to change that in the future as well. So for more information, you can contact any of these groups. It's the registry's website at the top, as well as our email. You can visit Collective Medical Technology to find out more about EDIE. And you can also find out about a lot of the technology information that we've discussed today, including registries in other states, electronic health record guidance that the POLST paradigm has developed, and more through the technology page at polst.org. So that's really it for me. So Adam, is there anything additional that you would like to mention for EDIE, maybe specifically about how the system actually works?
Certainly, I can take 2 minutes to walk you through the process. And so when a patient registers at an emergency department, hospitals, you can think of the registrar, would register that individual, type it into their systems. At that point, at this point, basically every hospital, including smaller rural ones, their information systems, the electronic medical record or the registration module, generates a piece of information with a specific formatting. That's a standard that all EMRs use for meaningful use, called HL7. That message gets sent to us in a secure fashion, and we process it. We then look inside the message. The message has information related to the encounter, registration information, so demographic information on the individual, chief complaint, those sorts of things. We'll pull out the demographic information to identify the individual against our master person index, and then we'll evaluate that individual with a set of criteria that hospital has established. And so our goal is not to push a notification or report for every individual, but to push notifications and reports for those that the hospital has written rules around that might be more complex patients or more patients with a higher risk profile, so that the physicians with their limited time can understand out of the 100 patients that come in for that hospital, or the 50 that doctor may see that day, that these individuals have some extra concerns to be aware of. If any of those criteria are met, those rules are met, then we'll create that curated report that Dana mentioned. and we'll push that back to the hospital. And as she indicated, we can send it through a few different mechanisms, be it fax or network printout, if the EMR system isn't able to do an integration. But if there's an Epic or a Cerner or Meditech or one of those other larger systems, then we're able to actually push it directly into their EMR so that it shows up typically on their track board. So the physician, before they even go and see the patient, they can see an indicator that there is an EDIE alert. That EDIE alert would have that utilization information, care recommendations for the individual, and a POLST document. In the case of Oregon, that could be at the ready for the physician to review and then hopefully make a more informed treatment decision and have a better conversation with the patient about what's going on with their health.
Thank you so much, Adam. So I am seeing that we have a couple of questions. Does a state need a registry to work with an HIE? Well, I believe there's multiple mechanisms to work with a health information exchange. The challenge is, if there's not a state-level registry, is that you can't be sure that you're capturing all of the information that you want. However, individual health systems or individual hospitals or even clinic-level HIEs that can share across care settings would have the potential to be able to utilize a health information exchange of some kind. So kind of a vague answer, but happy to follow up if we need. I know the questioner on that one. So next one, how does a state program connect with their local HIE? Well, first, I would say to start with the state health information technology group. There's usually in every state, there's some sort of health information group that is managing usually information exchange. Whether or not they have a statewide system in place, they certainly would know people to contact or groups to work with. So not all states have health information exchanges, and actually not very many have anything that runs statewide. Or if they do, it would be a little bit more specialized, like EDIE, which is focused on emergency departments, for example. There are some broader health information exchanges or health information organizations that are regionalized. And some are for-profit and some are not for-profit, and so it's really a state-by-state, it's state-by-state information that you have to find. So the next question, what EMR systems, if any, have POLST forms been integrated with? So if we're talking about ePOLST systems, then I have seen products built for Epic, for Cerner, for point-click care, for Meditech, for even some self-builds. And I'm trying to think, a variety of Epic builds, because if you've used Epic, you know that a lot of them are different. And some groups, some health systems have, as I mentioned, built their own that's integrated as somewhat of a smart form or module that's within their EMR. And others have standalone form completion systems that are directly accessible from an EMR, but are not actually housed within the EMR. So there's a reasonably recent report that I will pass on to Hannah to post with this information that describes some of the different mechanisms for electronic health records and maintenance of POLST forms. Are HIEs national? This is the next question. So if Florida is connected to their HIE, can they pull up Oregon forms because Oregon's connected to the HIE? Well, I think that there is a huge amount of interest in either national level registries or national level sharing of information. It's really kind of it's going to be a big push, I think, to get to that level. I do think that there is a lot of interest. If you look at the webpage of the Office of the National Coordinator of Health Information Technology, and I'll add that in as well, a little bit of a mouthful, they certainly will talk about measures that they've been trying to implement to have data sharing across multiple systems in multiple states and multiple settings of care. But one of the things you have to consider, again, is how many players that really is. and what is enough information essentially to have a tipping point where healthcare professionals or healthcare users, patients, see enough value in utilizing a health information exchange. The other thing, especially with documents like POLST, is there's variability in each state regarding legality of forms and different levels of validity. I certainly can say that the Oregon POLST Registry has received calls from other states because a patient has requested that from a provider or a legally authorized representative has, and it certainly has been able to guide conversation or treatment, but is not considered a legal document. Or, for example, in New York, there's a number of additional elements of documentation, checklists, and other things that have to go along with a POLST form to make it valid. So I do think that that's one of the challenges of having national level information or national level health information sharing. Okay, one more question or another. Oh, go ahead.
Yeah, I was just going to say one more question came in. Any advice on how? Any advice on how a developed POLST program can connect with HIE?
So, how developed a POLST program should be. That's a good question. I think that there often is a tendency to utilize technology for technology's sake. It's potentially pretty, and it's kind of the new buzzword, or people think that by having an electronic system of some kind, that will move their program actually forward. But I have definitely found in groups that I've worked with that having a well-infiltrated POLST system, along with very healthy outreach and education around guiding the conversation and having a successful completion of a POLST form, is what's critical for moving a POLST program forward, as opposed to just utilizing technology for access. You could have, for example, a self-submit registry of POLST forms or other documentation, but it's sort of a garbage in, garbage out sort of metaphor. If the forms themselves haven't been completed appropriately or up to quality standards with a good conversation, then there's not a lot of point in having a fancy registry. There are a lot of ways to utilize technology to move a POLST program forward, though. I definitely think it's a back to basics thing. Well, basics now. So utilizing webinars, utilizing information sharing through simple platforms where data can be stored or information can be stored that's accessible by a number of people with different levels of security. Having your POLST coalition or task force being able to meet electronically. Being able to, for example, have a Twitter account that you're putting out effective information, or working with your local health authority or medical board or hospice association, or any groups that you can get a handle on, to make sure that they're brought to the table to effectively disseminate POLST forms. And then, as you have POLST being strongly supported within your community or state, that's when I think that there's the best setup for significant technologic advancement that will support the utilization of POLST. So that's a really, really long answer, but I just think it's really important to focus on quality. No further questions. Please, again, feel free to reach out and contact our registry or HANA for more information. If you do go to our website here, you'll be able to see our annual reports as well as data, the most current monthly data report. Again, here, collectivemedicaltech.com. That's for more information about the potential to use EDIE and what EDIE is and how it works. And again, POLST.org/technology is a great location for finding information about what other states are doing as well.
Any other questions coming in? But again, everyone, please just reach out to us if you have further questions. POLST.org is full of information and resources. And any last closing thoughts?
I'd just like to thank everyone again for their time. And again, please contact us if there's any information that we can share. Adam, is there anything that you would like to share as a final thought?
No, just thankful for the opportunity to let you guys know a little bit about how EDIE is helping get POLST documents into ED physicians' hands more easily.
All right. Great. Well, thank you both, Dana and Adam, and have a great afternoon, everyone.